Good morning, everyone. Welcome to Primetime at Bethel Library. The Friends of the Bethel University Library collaborates with faculty development and other offices on campus to bring you programming that celebrates learning in and beyond the classroom of Bethel faculty, students, and staff. We're so glad you've joined us. Join us on Thursday, 2 days from now, when a panel of Bethel's healthcare graduates and Bethel faculty discuss healthcare grads at the front lines of COVID. Today, our presenter is Nick Zeimet, Assistant Professor of Social Work. Nick is in his first year at Bethel. Before this, he spent over a decade in the Twin Cities as a psychotherapist and social worker. He has worked with many populations of people and, while working with the Syrian American Medical Society, led that organization's first mental health mission to Lebanon and Jordan. Today, he will explore the who, what, and why of suicide, how to assess for suicide risks and threats, and how to intervene for safety. Let's welcome Nick.
All right, good morning, everybody. All right, I'm going to try really hard to just talk to you and not yell at you like I'm a loud talker. So you'll probably see me just really grounding myself as I go through this presentation to just talk. And the other thing you'll probably see about me as I go through is I tend to cope with stress and tension with laughter and jokes. And so if you find that at all through this presentation, know that it's not my irreverence to the topic. It's a reflection of how uncomfortable I'm feeling in that moment, and I'm trying to break that tension with a sense of humor. And I'm going to try really hard not to do that. So, because this is a serious topic that we want to have some reverence towards. So, thanks for being here, whether you're here willingly or at the strong recommendation of your professors. I appreciate it, and we'll hopefully have some learning together. So, as Ray said, thank you, Ray. I do come to Bethel, my first year here, as a psychotherapist and social worker for the last 10 years. I worked at a local hospital in St. Paul, both as a hospital social worker on our medical floors, doing crisis assessments in our emergency rooms, as well as working as a psychotherapist, doing one-on-one counseling in our mental health clinic. And so what you'll hear today, most of it just comes from my experience in working with individuals, doing assessments myself, doing crisis and safety planning. Just a note, the audience who I'm talking to today, this is mostly for our social work students, those in the helping profession, who are really going to have to know how to assess for and help people through vulnerable crisis moments in their lives. So we will work oftentimes with some of the most vulnerable people at some of the most vulnerable times in their lives. And so oftentimes suicide is something that comes up. And many of us have had exposure to suicide in our own lives, in our families. And so as you listen to this presentation today, there might be moments that you are just noticing you're becoming distressed, you're becoming uncomfortable, and you might just need to give yourself a break. And I just want to give you permission to do that. There's some nice cold water over there. You can take a walk out into the hallway, maybe try to ground yourself and then come back in. And if you're not able to come back in, maybe find a friend to just sit with for a little bit. But I want to make sure that you all know that it's important to center yourself, important to ground yourself, and it's okay to take a break if you need to as we go through today. So I'm learning as a first year professor that it's important to have learning objectives when we're in front of people. So this is my practice of saying, here's the objectives of our time together today. So I want to talk about just some key terms related to suicide and suicide assessment. We will talk about the scope of the problem. Want to understand what is the role of a generalist social worker when it comes to suicide. So as our BSW students are here, what might their role be as they are working with people in their settings? We want to understand the key components, what makes up a suicide assessment, as well as understanding what are the key components of a safety plan. So I would have done a good job if we can do these things by the end of our time together. All right, so some terms. Suicide. This comes from the CDC. Suicide is death caused by self-harm with the intention of dying, with the intention to die. So as you are working with people, it's real important to just differentiate for yourself intentionality. Sometimes people are self-harming, but they don't have an intention of death or dying, and there's other intentionalities behind the self-harm actions. And so one of the things we want to accomplish during an assessment is to understand why, the why. Tell me what you're trying to accomplish in doing this. Self-harm. So self-harm is the purposeful harming or hurting of oneself. So self-harm can come in different forms. Self-harm, some of the more common self-harm actions are cutting oneself, scratching oneself, pulling on your hair, pulling at different parts of your body, trying to cause harm to yourself. Attempt. So we want to talk about suicide attempts. An attempt is a failed suicide due to interruption, intervention, or failure. Okay. And we have suicidal, what's called ideations. A suicide ideation is having thoughts of suicide that may or may not include intentionality. So it's not uncommon for people to contemplate in passive or real intentional ways not living anymore. And part of our job is to make space where we hear people express their ideations. What are their thoughts? What are they thinking about? And then try to determine, again, what is the intentionality behind those thoughts? Is this something that you've thought about, but you haven't planned, you haven't really considered this? Or is this something that not only have you thought about, but you also are going to be planning, have plans behind it? So suicidal ideations, you'll hear that quite often in your different settings. Method. So method is just what we would refer to as the choice of suicide. So again, as somebody has suicidal thoughts, have they given thought to a method of how they might kill themselves? Through overdose of medications, of substances? Are they considering using a firearm, shooting themselves? Are they considering jumping from a high surface? Are they considering walking into traffic? Is there a method they've been contemplating or considering? Plan. So a plan is a detailed and thought action plan that includes some of the things we've already talked about. So somebody is beginning to plan their suicide when they've given thought to a method, when they've given thought to a place, when they've given thought to when. And so again, we'll go through this when we go through our suicide assessment, but anytime you hear somebody you're working with start to identify specifics about their suicidal thoughts, our concern increases with each of those specificities. And then intentionality. So one of the things we're trying to ascertain during an assessment is what's your level of intention on acting on this plan? Is it something you intend to do? Is there an imminent risk or danger of this happening? Do you have access to the method that you are contemplating? These are things we're doing in an assessment with somebody. All right, so we're going to talk a little bit about the scope of the problem. This all comes from the CDC. So over the last 20 years, there's been a 33% increase in the rate of completed suicides. In 2019, so this would have been, again, pre-COVID, pre-pandemic, 47,500 deaths in 2019. That comes out to be 1 every 11 minutes. In 2019, 12 million adults, so again, we're just talking about those 18 and older, 12 million adults seriously thought about suicide. 3.5 million adults planned a suicide attempt, and then 1.4 million adults attempted suicide in the year 2019. Again, more from the CDC. Suicide is the second leading cause of death for people between the ages of 10 and 34. This is important for especially our students, because many of you guys will be finding yourselves working with this population in schools, middle schools, high schools, and again, 10 years old. I've got an 11-year-old. I've got a daughter who's going to be turning 10. We're talking 4th grade, 5th grade for the lower end of this spectrum. So elementary schools, middle schools, high schools. And we also understand that people have siblings, people have family members affected. So even if somebody you're working with hasn't attempted, again, there's a good chance that they know somebody who is important to them who has. 4th leading cause of death for people 35 to 44. 5th leading cause of death for people 45 to 54. And overall, it's the 10th leading cause of death in the United States. Some of this can be really jarring. Again, the 2nd leading cause of death for those 10 to 34 is a pretty jarring statistic. Older men have the highest suicide rate of any age group. I forgot to put the age in here, but the 45 per 100,000 is for white men over the age of 85, compared to all ages, 11 per 100,000. So I think Ainsley, in her statistics course, or research course, would probably say that's pretty significant, that difference in there. All right, again, according to the CDC, who's affected? Well, the highest rates of suicide are among American Indian, Alaskan Native, and non-Hispanic whites. And some of the other populations, special populations with higher than average rates would be veterans, those living in rural areas, and young people identifying as lesbian, gay, bisexual, or transgendered. All right. So again, this is important because as social workers, we work with vulnerable populations in vulnerable situations. We work with stressed people. We work with marginalized populations. We work with discriminated populations, abused populations, traumatized populations. As social work students, our social work students are placed in many of the settings that are working with people in these different populations: schools, hospitals, community centers, before and after school programs. Just this year, we have had 2 or 3 moments where a student has come into contact with somebody who have expressed a suicidal thought. And they have had to figure out what to do with that thought, talk it over with their supervisor. So it's something our students are coming into contact, and if they haven't come into contact with it yet in their field, they will. There's very few things we can say you will experience in your career, in your profession, but this is one of those where I can guarantee you're going to come across it at some point. So, suicide assessments, a thorough suicide assessment, it should be conducted by a trained mental health professional. Our job as generalist social workers is not going to be to conduct a thorough mental health assessment or to determine somebody's intentionality for suicide. Most of you, your role as a generalist social work professional and student is going to be in the realm of screening, referring, helping connect people to what they're needing next. So, what is your role as a social work student or as a social work professional? I'd say first, it's to be competent and professional in your practice. Part of what your training is to teach you what to do when you're talking with or interacting with somebody who's expressing thoughts of harming themselves, who has thoughts of no longer wanting to live. You don't want to be practicing into something that you're not trained for. And so if you're not a trained mental health professional, you don't want to be doing a mental health assessment. you want to reserve that for the mental health professionals. So you want to be competent, practicing within your scope what you've been trained to do, and referring on to somebody if you're not trained in that area. So it's part of ethical practice to be able to do that. Safety is always our primary concern, and so we elevate safety ahead of some of the other ethical standards that we might carry as social workers. Confidentiality, privacy, self-determination, these are all things that are important to us in the work that we do with our clients. But when we have somebody who's threatening hurting themselves in a terminal way, like suicide, we carry that as a higher ethical standard. So sometimes that might mean breaking confidentiality in connecting that person to the next level of service. It might mean countering somebody's self-determination and saying, we have agreed as a society that we're not going to allow you to hurt yourself, and so we're going to bring treatment for you. You may need to call 911. Again, if it's not my scope of practice, if safety is my concern, it might mean that you need a paramedic or an officer to intervene to help get and transport somebody to a place where they can be assessed. And I messed up my words here. The intentionality of this was to maintain the dignity. Oh no, I did get that right. So maintain the dignity of the person you're working with. So while we're working with someone, we don't want to communicate shame or blame or guilt. And so again, this is just being grounded, being trained, knowing what we're doing, our intentionality. We want to maintain dignity while we're working with people. So our role is we want to be assessing or screening for safety. Is there an expressed desire to no longer live? Might come across in real specific ways. I want to die. I'm going to kill myself. May also come across in more passive statements. Things like, I just can't do this anymore. It'd be easier if I didn't have to wake up. These are things that we might hear that we would categorize as more passive statements. Nobody in those statements, they haven't said that they want to kill themselves, but there might be that intentionality or idea behind that statement. So we're not going to read into the statement, but we are going to have some concern and maybe have some follow-up questions for our client. So some of that might include, is there a method? Is there a plan? Is there intentionality behind your statement? So interventions, when suicide ideations are present, but there's no intention on acting on that. Again, if we go back to some of those previous statements, this is just so hard, I don't know if I can do this anymore. I just don't know if I want to wake up in the morning. But as we follow up with some questions, they're not intending on killing themselves. It's a reflection of how stressed they are in a moment, a reflection of how much chaos there is going on. It's a reflection of where they find themselves in the semester. So there's no intention. What we might want to do in that moment is we do want a safety plan. Anytime somebody makes a comment, whether it's real specific or a passive, we don't want to just let that go. We do want to have an intervention or a follow-up. So it might be a safety plan. It might be that you want to refer this person. So again, when suicidal ideations are present, but there's no intention of acting on it, you may want to refer this person to a behavioral health, mental health professional, to an outpatient program, to county crisis services. You might even direct them to an emergency room to get assessed, but you're doing it under their, with the understanding that they will go. And again, when suicidal ideations are present, and there's some level of intentionality or uncertainty, you might want to call 911. Depending on your setting, it's always something you want to determine, and you want to ask, what is our protocol in our setting when somebody is suicidal? All right. Now, for those mental health professionals, sometimes it's important for you to know, as this person presents to the emergency room, as they talk to a mental health professional, what might that assessment look like? What information might I want to provide to that next level of care, that next service? So the goal of a suicide assessment is to determine intentionality or threat level of the suicidal ideations. It's done through a mental health history by a mental health professional. And here's some of the questions that a mental health professional might walk through with somebody who's expressing suicidal ideations. We might want to explore, is there a present or a historical mental health diagnosis? Are there previous attempts at suicide? And if there's been previous attempts, what went on in those attempts? Were those attempts interrupted? Were those attempts incomplete? Were those attempts aborted in some way? Did somebody decide to change their mind as they began walking something through? Is there a family history of suicide? Oh, thank you. Is this something that goes on within your family? Is there a history of trauma? Again, it's important to survey these issues because these are some of the risk factors that would exist. So is there a history of trauma in your family? Is there a history of abuse that has gone on? When was the onset and what's the duration of these ideations? How long have you been thinking like this? Has it been a week? Did it just start today? How frequently are you having this? Is this thought here all day long, or is it kind of come and go? Are you able to control these thoughts? Are you able to manage them, navigate them, or do you feel helpless to your suicidal thoughts? So we want to explore this sort of thing. Again, what's the frequency? How often do they come? Is it seem like every holiday season you have these thoughts? Is it every time you get together with your family? Does it happen every time a certain anniversary comes around of something that went on in your life or with your family? Are there substances present? This is important because substances can interfere how we're thinking. And so it's possible for somebody to have suicidal ideations, to be expressing a method, to maybe even talk about a plan in the context of inebriation. And as they sober up, those thoughts no longer are present, they don't remain. And so we want to know, is there a substance that potentially is present? It might mean that the intervention is to simply allow somebody to sober up and to give them time. And then we do some safety planning as they come out of that. Are there acute stressors? So again, are the holidays coming up? Is there been something traumatic that went on in your family? Do you have finals coming up, right? Is there a trip that you're getting ready to take? Is there some news that you're anticipating having to share with somebody? Is there a medical diagnosis that you just received or somebody you care about just received? Is there something going on in our society? Is there a trial that's just starting? Is there news that you just heard on the evening news that's upsetting for you? These are all things that we're talking about. We're trying to bring out in a suicide assessment. An answer to any of these isn't necessarily indicative of, okay, here's what we do. It's all part of a puzzle. So one of the things we're really trying to teach our social work students is critical thinking, professional judgment. Not every situation is the same as the next situation, right? And so the stressors that might exist for one person may be different for another person. A situation for one person may be different for the next person. Our job is really to try to synthesize all of this information together and determine risk, determine intentionality for the person we're sitting in front of in that moment. So, some of the tools that we use while, or in addition to our clinical interview, are different assessment screening tools. So as a generalist social worker, these are some screening tools that you might have at your setting. If you are a mental health professional, you might use some of these instruments to supplement your clinical interview, to give you more data, to add validity to your conclusion of risk for this person. Probably the most common tool that is out there is something called the Columbia Suicide Severity Rating Scale. And it looks like this. It's a pretty long scale that can be, it can be long or it can be short depending on how somebody answers it. Just yes, no questions, and it really breaks up the questions in over your lifetime. Have you had any of these thoughts over your lifetime? Have you been thinking in this way? And over this past month, have you been thinking this way, having any of these thoughts? It goes through asking people, even if you've had the thoughts, have you had these thoughts with a specific method in mind, with a specific plan in mind? What has your ability to control the thoughts looked like? It really helps you as a professional try to understand what is the risk level of this particular person, okay? And again, adds validity to your assessment. Free, it's available. There's some training resources that will help you know how to use the tool. And I would suspect a lot of your places, as social work students anyway, your supervisors, I'm certain, are familiar with this, that can help you engage in the training that's necessary to know how to use this with somebody. Similar to that, another tool, and is just a quick 1 through 6 guideline. Again, from the CRRS is this 6 questions that we can just be asking. Again, we just come down here. A yes to any of the questions indicates concern and would probably have you engaging in a referral of this particular person to a behavioral health specialist. If there's no's up here, then there's probably no concern, and we move on. In questions 4, 5, 6 here, if somebody is indicating yes to these, it really helps us to determine the risk here is high, and we might want to have more of an immediate intervention. Referring this person to an emergency room. If you're in a setting that is able to keep somebody in that place while emergency services come, because the threat level is just much higher. And then again, we're looking at things like you have had a thought of suicide in addition to having a method in mind, in addition to having a plan in mind, and in addition to having some intentionality behind your thought. All right, here's another 5-step example that comes from SAMHSA, the Substance Abuse Mental Health Service Administration, has a 5-step process of evaluating and triaging. Identify different risk factors, identify the different protective factors, conduct a suicide inquiry, again, thoughts, plans, behavior, and intent, determine the risk level, intervention, and then document. It's a real quick, easy resource that you can have available to yourself. All right. Safety planning. When screening has determined that someone's suicidal ideations are not an immediate risk or a threat, at that time you might think about making a referral to a crisis service or an outpatient mental health service. And in that situation, what you would want to do is not only would you want to refer, but you'd also want to engage with the person you're working with in some sort of safety planning agreement. Again, safety planning, it's demonstrating competent professional social work. In the safety planning, you're going to want to highlight protective factors and spaces that ground. When we say ground, just grounding yourself. So these are spaces that help you get back to the present moment, out of your mind, and able to identify where you're at with your surroundings. So in our safety assessment, or I'm sorry, our safety planning, we would want to identify people that can accomplish this for you. Maybe it's a friend, maybe it's a parent, maybe it's a peer, a partner. Places. Are there places you can go that are going to help ground you, that help you collect your thoughts? Maybe it's a park, maybe it's a church, maybe it's somebody's home, sitting around somebody's dinner table. Are there certain activities that help you? Do you need to go to the gym? Do you need to go shoot some baskets? Do you need to get to a chapel? Do you need to pray? Do you need to talk with somebody? And then they also include professional resources, crisis contact information, that sort of thing. We always want to make sure that part of that safety planning does include presenting yourself to an emergency room. If the first steps of the plan have not helped your suicidal ideations. I have found one of the greatest challenges to encouraging somebody to present to an emergency room is the sense of failure, the sense of shame, the sense of the emotional things that go on for somebody when they take that step of presenting to an emergency room. So part of our work is really wanting to coach the people we're working with to see that not as a failure, but to see it as a continuation of their safety plan. So you might start off with, when you're feeling this way, when you're having some of these thoughts, your first step might be to talk to your partner, talk to a friend. And then we might talk to people about it. If that doesn't seem to work or that's not seeming to help, maybe you talk about, why don't you take a walk, grab the dog, take them out for a walk through the park. That's both a place, it's an activity. If these thoughts seem to continue, are there some professionals you could call? Is it a social worker you've worked with in the past? Is it a counselor? Is it your doctor? Can you reach out and make a phone call to? And then there's just a natural progression. We would talk to people about next, if that still doesn't seem to be helping, go to the emergency room. It's just a part of the natural progression of how you're taking care of yourself. Really trying to normalize presenting to the emergency room as something that is taking care of yourself. Helping people understand that our mental health is not that different than the pain that you might feel in your stomach, the pain that you might have in your back. And when it gets to the point when it's no longer attainable for you to just have that, you present to someone and let them know that this is interfering now with your life. And so we're really trying to incorporate that presentation to the emergency room as something that's non-judgmental, non-shaming. And then we want to be documenting the whole process, right? So from the beginning, what have people been saying? What were the words they said to you? What was your assessment? Did you screen this as something that was high intentionality, high level threat? And if so, how did you come to that determination? You want to include that in your documentation. If it's something that you determined as low risk, low threat, then you want to be documenting the safety plan. I'd encourage you, as you guys are doing your safety plans, that you document the safety plan and that you send the person you're working with also with a safety plan. You should both have copies of that, and it should be stuff that you follow up with, that you come back and review together. So, some examples of this. Again, we're going to go to the Suicide Prevention Lifeline. This is a pretty standard safety plan here I used in my practice, and I think other people generally use. It's a lot of the things we talked about. Helping people understand what are the warning signs. How should I know when I should be concerned with my thoughts, with my mood, my situation? What are some of the internal coping strategies? So things I can just do without contacting anybody, or perhaps needing to connect with someone. So I might do a relaxation technique, I might meditate, I might pray, I might go for a walk. Again, step 3, if that's not seeming to help me, Are there people in social settings that might provide distraction for me? Name them, be specific. Like any plan, when we become more specific, we're more likely to connect with that person, to follow through on that thing. So if we say to ourselves, I'm going to go to the gym this week, but we don't say when and where, we might make it to the gym, but we're more likely to make it if we say Tuesday night, 7 o'clock, I'm going to go to the gym. So let's identify the people, the places you're going to be going to, name them, put the phone number down, people I can ask for help. So this would be beyond distraction. Edie might provide a good distraction for me, but she may not be somebody I want to go to and kind of be vulnerable around. So who can I go to that maybe I can be vulnerable around? These are different people. So again, name them. Might be some of the same people. Name them. What are their phone numbers? Have it be easy access for somebody. If that's not seeming to help, who are some of the professionals, some of the agencies I can go to? Is there a counselor? Is there a therapist? Is there a doctor? What urgent care, what emergency room might I present myself to? And then step 6, making my environment safe. What do I need to do to make my environment safe? Do I need to make sure that firearms are out of my house? Do I need to call somebody? Do I need to say, how about we do that together right now, instead of saying, I think you'll do that when you go home? Do I need to talk about putting my medications in a different place, or having somebody supervise my medications? Do I need to talk about taking a break from something? Is that what making my environment safe looks like? Does it mean I stay home this season for the holidays instead of being around my family? That can really cause me a lot of distress. What does that look like to make our environment safe? So we want to have that conversation with our clients. All right, just another example here. This comes from the VA. The VA has again, a nice little tool to just help you walk through implementing a safety plan with somebody. Gives you some cues on some of the questions you can ask. And so I'd recommend, again, these are a lot of just easy to grab, easy to use resources as you're working with somebody. And then lastly, as a general social worker, again, part of your job is advocate. Help to reduce the stigma around having conversations around our mental health. Part of the problem that exists is all of the shame and all of the guilt that a lot of us walk around with in silence. And so the more that we can encourage one another to talk, the more that we can encourage the people we're working with to become aware of the emotions, identify the stressors, it all just helps reduce this overall stigma. We're really normalizing conversation around stress and mental health and sadness and depression and even thoughts that we might be having. Advocate for access to services. Part of what goes on is we've got bottlenecks of people trying to get in to see psychiatrists. You go see somebody in an emergency room, like myself, they do an assessment, they refer someone out to counseling or therapy, and oftentimes you can make that happen in a relatively quick way. But if you're trying to get someone to see a medication specialist or a psychiatrist, oftentimes, depending on your location, that can be several months out. And so what are the services available? What's the funding looking like? Providing funding to mental health services. So that can be advocacy that we can be doing at our legislatures and with our representatives. Different resources. Get yourself familiar with SAMHSA, the Substance Abuse Mental Health Services Administration. They have lots of resources, lots of free resources, lots of free tools. Become familiar with that. Become familiar with NAMI. NAMI does a lot of advocacy. NAMI does a lot of education. NAMI's got a lot of resources. Be familiar with NAMI, and then be familiar with the National Suicide Prevention Lifeline. Be familiar with your county crisis services, what's available in your county, what are the numbers to call, what does the crisis services look like in your county, do they have mobile crisis services in the county you work in, do they not, what's that phone number, become familiar with these things. And with that, I think we have a few minutes here for questions, if anybody has any.
Nick, I just had a comment. I wanted to say that one of the theories that I really like in social work is the hope theory. And in one of those assessment tools you had at the very bottom under number 6 was like, what is the one thing that you most want to live for? And I think that I think this is really helpful, even if you're not a social worker, is just how to apply these within our families, but that hope piece and that resiliency piece. So I'm just wondering if you can talk a little bit about, in your experience, have you noticed when you touch on those things that it impacts how people are feeling? Like, how important is that?
No. Well, I think hope. So the comment in question was around hope theory and this idea of identifying something to live for or something to kind of look forward to. I think it depends on the populations that we work with. I think some populations we can connect to that idea of hope, and people have a sense of something that they're looking forward to. Some of our populations have a really hard time identifying that, and so a lot of it just depends on what your role is in that moment. So if you're working long term with someone and someone's got low threat level, and so the suicidal ideations they have might be persistent and chronic, but you've determined that there's not an imminent risk, you might have time to really explore some of those concepts with people. Sometimes people in that crisis space, it's hard for them to identify those hope pieces, especially some of those populations that have been marginalized and have got such chronic nature to their situations. And so those times, again, if we're working with someone in longer term situations, we might transition a little bit to like a values conversation as opposed to identifying those areas of hope. So yeah, it really just kind of depends on, do I have time to explore that hope piece with somebody? But that is something, I mean, oftentimes exploring a reason, what would keep you from doing this? What keeps you from acting upon that? Really getting people to touch base with that, especially, and again, when the threat level is low, I think there's more of an opportunity to do that, really trying to orient people to the why not. Yeah. Anybody else? Yeah, Ashley.
How do you as a professor approach supporting students who might be encountering suicide for the first time, who aren't yet social work practitioners, who are still learning how to navigate these situations?
Yeah, so the question was, how as a professor, and tell me if I'm summarizing, I'm going to try to model my summary skills here, right? So tell me if I'm summarizing your question right. How as a professor, can I help students who might be having, was that it, suicidal ideations themselves? No.
Encountering clients
who
are struggling with suicide for the first time and aren't yet practitioners and are still learning.
Gotcha. So, so a couple things, so question was for either non-social work students or social work students who are just encountering clients for the first time. Am I summarizing this better now? Thoughts I have for them. So what I would say first is I want to go back to that concept of maintain the dignity of the person you're working with, right? And so validation and affirmation. And we want to be careful that what we're not necessarily validating is the hopelessness, but we're validating the emotions that kind of put somebody in that space. So really joining up with somebody in stress and struggle and strife and disappointment and going, trying to identify and affirm what it's like to just be human, and we get disappointed and we get overwhelmed. And so I think that's the first place I would start, is validate in that space. The second thing I would do is don't be afraid to just ask the question. I think when I was a beginning practitioner, it was really difficult for me just to bluntly ask somebody, have you thought about killing yourself? You can't really come back from that question. Like, it kind of changes the temperature in the room when you ask that question, but sometimes we just need to ask the question. Instead of dancing and really kind of developing anxiety in ourselves about not knowing where that person's at in their mentality. So I would encourage you to not be afraid of just asking the question. And now if they say, yes, I have thought about it, I would encourage you to look up some of these resources. This is part of that competent professional. Like, you're doing some of your own work at trying to be ready for some of this stuff. And so ask through some of those questions. Is that helping, Ashley? Okay. Yeah, I think one of the biggest things is just it feels really scary to ask that question. And I think what we're really afraid of is if the person says, yes, I am thinking about suicide. I am thinking about harming myself, killing myself. And oftentimes we're afraid because we're not sure what we would do in that moment. What do I do with somebody who says they are thinking about killing themselves? And again, this is where I would just really recommend that part of our role is not to take them from thinking about killing themselves to not killing themselves. Oftentimes, like, that's not what we're being asked to do. We're being asked to determine if this person needs to be in the presence of a professional to assess that. And so we ask those questions to try to determine that. Remember, we're trying to keep people safe. That's our number one goal. Any other questions? All right. One of the things I impressed upon our social work students before we broke for the holidays, and I would just continue this from this point to the end of the year, is our person and environment theory, right? Our perspective. Recognizing, especially on a topic like this, one of the things we want to do is just recognize the environments that people find themselves in. And in a season when we're watching others get together and have family moments, have joy, have all sorts of things that they're seeing. Sometimes what we're reminded of is, number one, we're reminded of maybe we don't have those things, or the people you're working with might not have those things. There's a lot of comparison that goes on during seasons like this. Number two, because there's so much meaning and sentimental activity that happens during the season, sometimes or oftentimes, if we're not able to have that because somebody who was here last year at this time is not here this year, again, those anniversaries can be really moments that are really difficult for us. So we want to understand that this is the space that not only you might find yourself in, but your clients, your students, your patients, they might find themselves in these spaces. And we also want to be mindful of what's going on in our community right now. And so we, as social work students, we're very mindful about the last few weeks and some of the things that are going on. Some of the trials around our criminal justice and equity in our criminal justice system that is happening right now, and how different populations might be interacting with those trials and the verdicts that are coming from those trials. Today started another one of those. We want to be mindful about some of our community that might have higher degrees of stress and distress, and person and environment really connects us with that. And so as people start talking, we want to understand, what they're sharing, is it in the context of something larger that's going on? News over the weekend of a new variant of COVID might have a lot of people's anxiety levels up. And so these are things that we just want to be mindful that as people start sharing things with us, we can validate their anxiety, their fear, their anger, their distrust, their discouragement. If they're struggling with hope, we can identify that and try to affirm that position. And again, don't be afraid to ask the question if all of those emotions are bringing them to a space of hopelessness where they're thinking about killing themselves. Don't be afraid to call 911, to have somebody safely transport somebody. Don't be afraid to talk to your supervisor or to another colleague about how to help this person. And be present for the people you're with. I think that's the number one thing we can do. So All right, y'all. Thank you so much for being here.